Hello, I'd just like to talk about the future of orthopedic training. These are my views based on my observation of the current dynamics that is occurring in healthcare and also in education, both locally and internationally. It's also based on the evidence in the literature about postgraduate training and my own research based on the motor skill acquisition among surgeons. Let's look at the current status of the um, orthopedic training. I think it is important to first look at the demand and supply. At the moment, the demand for orthopedic surgeon may not have been as high as before, and the supply is a bit higher than the demand. I would eventually see that the demand may be filled with the coming out of orthopedic surgeon, especially in the public sector, and also I would see in the private sector. And this demand and supply is dependent upon the interest of postgraduates to take a career in orthopedic training, which is arduous and rigorous, and people may opt for other forms of specialty. And even I think there will be an issue in recruiting medical students in the future as people look at alternative careers. The future of postgraduate training, I think, is going to be very challenging. The other important area, I think, is to look at generality and speciality. There is evidence in the literature that subspecialization is not necessarily good for the population as a whole. As we have more and more subspecialization occurs, there is a lack of general competencies for individuals to practice. And as subspecialization volume may reduce and people go back to promotive and preventive care, generality may be a bigger important and value in the community as a whole. A big area is in orthopedic training has been the emphasis on competency and not mastery. And I think this needs to be addressed by the current stakeholders to understand that competency is just enough for certain specialties, but in high stake outcome specialties like surgery and orthopedic surgery, we require mastery. And the training program for mastery is quite difficult and and different from that for mere competencies. So we're not looking at minimum level, we're looking at maximum levels of mastery. Mastery is dependent upon time-based and activity-based practice of motor skills. The importance of non-technical skills cannot be denied, but I think the obsession with the non-technical skills in surgery has diluted the importance of motor skills, which is for mastery. And I think we need to address this. Obviously, mastery cannot be achieved in all motor skills. So the importance of curriculum redesign to understand what are the needs of the community and redesign the mastery for the procedures that are needed in the community. The other important aspect that we need to think about is equitability and inequality. So whether we are having sufficient amount of manpower in the public sector where most of the major common and urgent procedures are being conducted, and the inequality in terms of distribution of personnel between the private and the public sector. Also, the access to specialized care, whether subspecialty care should be directly assessed by the patient, or now as the country moves towards general practice and primary care physicians as gatekeepers, maybe we need to look at that and similarly bring that along to orthopedic practice where the general orthopedic surgeon would refer to the subspec rather than the patient gets directly referred to subspecialty. And I think this is important in terms of social justice and efficient utilization of resources. I think the trend will move towards a consultant-led service rather than and the consultant delivered service. Now, at the moment, we are very familiar with the consultant-led service, but we are also seeing the trend from the Ministry of Health that they require consultant-delivered service, and I think this will become more and more apparent. This produces challenges for opportunity for surgical skill acquisition, and therefore this has to be considered as we design our training program. So the specialist-centered kind of practice that we are used to will move towards a general practice-centered practice as we are aware of what's happening recently with the Ministry of Health directive. And this will move towards that where the stakeholders and the gatekeepers for healthcare will be the GPs. And we need to look at ways in which the training and the delivery of service need to take this into consideration. The other thing to look at is the procedure-based and value-based. So as orthopedic training, we are focused on skills, motor skills, and procedure. We need to revisit the role of whether this adds value to the patient and to the community. And this is quite a serious issue that has got impact in curriculum development. So what is the problem that we have at the moment? As I see, the problem is the short duration. Trying to produce a master surgeon at the end of a 5-year period, I don't think it is possible. We need to therefore identify procedures there where mastery is required. And this is very clear with clear descriptors of what we expect in mastery. So this requires a revisit to the curriculum. We are a low volume based practice in Singapore. So we need to find alternative ways on how this can be overcome with the use of non-practice-based skill acquisition through the use of technology, AI, VR, and also simulation. And the demand for early subspecialization needs to be revisited. And I think that the general orthopedic surgeon post-training and residency should not be allowed to subspec very early. I think it is important that subspec should be reserved for those few who are genuinely interested, as the demand for generalists still is very high in Singapore, and I think this is important. This has resulted in also the loss of general skills, that we find somebody 5 years post exit of a residency program having lost the skills in general orthopedic practice, and I think this needs to be addressed. This is in my view. Obviously we need evidence for this, and we'll come to that later. And one must understand that the government is also aware of the rising cost of practice. The rising cost of practice, one of which is in the easy access to subspecialization, the use of non-evidence-based procedures being used and being paid for by public sector and by the patients themselves. This cost of practice will eventually bring about audits and restraints in practice produced by finances of healthcare, which we are already seeing. The change in technology and the change in our practice is important, and this has to be taken into consideration as we design our training programs, and we need to incorporate this into our curriculum. If I'm not mistaken, the last time we looked at our curriculum was about 10 years ago, and it's definitely time for a revisit to the orthopedic curriculum. What is therefore the need? The needs is we need an evidence-based planning and training framework. We need to look for the evidence. What is the curriculum? What are the procedures that we need to train our postgraduates in, and what kind of techniques we need to incorporate in our training program so as they obtain the masterly skills rapidly. I would focus at this moment on the motor skill development. I think the knowledge and attitude and professionalism has been adequately covered, but I think having surgeons who are unable to operate, I think will be a disaster. However good your communication skills are, you cannot counsel an inflamed appendix out of the abdomen. We need motor skills. The framework that we can use to understand this problem and to learn from it is the transdisciplinary research. I'll provide a slide later on what this involves. And therefore, we need to look at all the stakeholders who are engaged or involved in the orthopedic service in the country. And this requires not just health professionals and subject matter experts, but also the social scientists and financiers, economists. So a multi-agency approach towards understanding the problems in orthopedic training. So we need to, once we have identified the stakeholders and the multi-agency involved in orthopedic training, then we need to engage them and get their participation so that there can be a process of co-learning from each other of the various issues. So once we understand, say, for example, what are the employer's needs and demands are for an orthopedic surgeon, then the training program can address these needs. And through this process of co-learning, we can then identify the crucial problems that exist in the current training program, from which we can then generate solutions, and then we can select and implement solution, and then obviously monitor and evaluate, which you are familiar with this sort of system. So what do we do now? And I think it's important that the residency program and all the multi-stakeholder agencies need to initiate a task force and to commence this transdisciplinary research to understand and learn about the problems, challenges, concerns, and expectations of stakeholders in orthopedic training and delivery of care in the community. Once this TDR process is commenced, then we'll be able to identify meaningful and smart solutions, specific, measurable, achievable, realistic, and timely solutions that we need to be able to bring about a training program that meets the needs of all stakeholders. And these are some of my thoughts about the possible implications for residency training. Obviously, as I mentioned, we need to revisit the curriculum through this TDR approach to understand, learn, and be evidence-based. And we need to prepare for general skills development to a level of mastery. And the use of simulation, lab-based skills mastery, and the use of augmented reality and virtual reality is going to be a big part. And the creation of AR and VR objects in the learning program is going to be crucial to help in motor skill acquisition. We need to move away from time and procedure-based to more outcome-based credentialing. And I think, again, going back to generalist and suspect, this needs a serious view, but we need to get all stakeholders involved. And the generalists need to be the gatekeepers to suspect practice. And this may be controversial, but I think overall this has to be driven by the regulators and policymakers in the country to maximum utilize the resources and to avoid issues of value. We must make sure we have a value add delivery of care. And I think it's also another important aspect as the primary care practice in this country expands. We need to think of considerous ways of embedding orthopedic care within the community and also provide training through the community-based practices. This is the diagram on transdisciplinary approach. It's quite comprehensive. I have developed this through other models that I've used in transdisciplinary research, especially health and social sciences. This is something that I think the residency program needs to look at and take this forward and maybe initiate this on a national scale. Thank you very much. Apologies for taking too much of your time.